So like Bruna said, my name is Kara Cruz. I'm a project officer here at the International Federation on Aging, and it is my pleasure to be able to speak with Mr. Darryl Barrett from the WHO today. So Darryl Barrett is a health and legal professional with 25 years experience in service delivery, public policy, regulatory reform, and program development. He has over 14 years experience advising governments and civil society in more than 30 countries across the Middle East, Asia, and the Pacific. This has included living and working in fragile and conflict-affected states, middle income, and well-resourced settings. So Darryl is currently the lead of the disability program at the World Health Organization headquarters in Geneva. He's responsible for managing the development and coordination of guidance, advocacy, and capacity building on disability inclusion in the health sector amongst member states and global partners. And then prior to this, he worked with the WHO Regional Office for the Western Pacific, working on disability and rehabilitation and health law and ethics. So Darryl, thank you very much for joining us today. Just to start off, so Geneva is a long ways from Australia. How did you end up so far from home?
Thanks, Kira, and good morning, good afternoon, good evening to everyone. Thank you for inviting me to speak today. I guess it is a far away from home, but you know, these days you're only a sort of short hop on the airplane away. But I've been with WHO now for about 7 years, and as you mentioned, I was about 5 years in the regional office in the Western Pacific. And I think now it's safe to say that WHO is really stepping up our action and our game in terms of disability inclusion in the health sector. And my career has pretty much always rotated around disability and health and the law in some degree. And so it feels quite natural to be here at this time when WHO is really moving forward in this space.
Yeah, for sure. So how did you kind of become interested in disability and law? How are those two things connected?
Yeah, look, I think I always wanted to be a lawyer, but I think like many of our kind of childhood dreams, the dream and the reality are very, very different. And so I really started my career in healthcare as an occupational therapist and deferred any studies in law, but then came back to it later, did my law degree, got my master's, got admitted, and really kind of amalgamated the two. And as most of, I'm sure the people online today will know, that disability is not the same thing as a health condition, that there is a huge legal and human rights component to disability. So health and the law really kind of went hand in hand in terms of contributing to my career. And then you throw in the development aspect, and I saw Diana Hiscock just pop up on the screen before, and I actually took over a position that Diana was in Jordan for humanity and inclusion. She moved out of that role, and then I came into it. So yeah, it's kind of those three elements all came together.
Okay, I see. So to what extent then do you kind of base what you work on now with your experiences kind of on the ground in a more practitioner role as an OT?
Look, I think my OT training has been really fundamental, because if anyone knows anything about occupational therapists, we usually get handballed the difficult situations to deal with, and we often have to think outside of the box. And also we're not medical professionals in the strict sense. You know, when we are working with patients or clients, or however we want to describe the people we work with, it's usually in a very, very broad problem-solving based approach. And so that I think gave me a really good grounding to apply in the work that we do now in WHO. It's really is a privilege to work so close with governments to try and tackle some of the challenges they have in the health system, looking at what can be done in a realistic manner, because governments, whether they're rich or poor, always have a finite budget to work with. And so when you've got to advocate why we should spend X amount of dollars in this area as opposed to X amount of dollars in that area, it's always important to try and be as practical as possible. So I think I was lucky to have that sort of early career experience.
Certainly. So kind of understanding that the forms in which marginalization occurs reflects to some extent like access to resources, as well as social values or social understandings of impairment or disability. What has been your experience working in such a large variety of countries and communities throughout your career?
Yeah, look, it's a great question. I think marginalization is pervasive across every community, every country, regardless of their resource level or their culture. And I was thinking about my time in Afghanistan, which was my first kind of development experience. And it's interesting, you know, given the context in Afghanistan with the conflict and post-conflict and protracted conflicts, that many soldiers who were wounded and had an impairment and developed a disability as a result of conflict always considered themselves differently to people that may have been born with a health condition or impairment like cerebral palsy. And so there was this further marginalization even within the disability community about, well, who's really you know, disabled on good terms versus, you know, who's everybody else kind of thing. So we, you know, that's one example. And then if I look to my own home country of Australia, where we see we have a national disability insurance scheme, and some of the people on my line might be familiar with that. But because of the policy settings, it cuts off at the age of 65. So if you are over the age of 65 and experience disability, you are allocated onto a different aged care scheme, which many advocates are really unhappy about because it doesn't provide the same level of supports in terms of you know, community supports and assistive technology and a range of other programs that the National Disability Insurance Scheme does provide. So, you know, even in Australia, you can have people saying, well, we're marginalized because we don't have access to the same types of supports to enable our independence. And that's a policy, you know, setting that that the government now is looking at. So, yeah, it's very broad, but it's in every community.
Yeah, certainly. So for anyone in the audience who is unaware, last week, the Global Report on Health Equity for Persons with Disabilities was launched. And you kind of speak about this kind of disjoint between policy and kind of needs of individuals. And also in the Global Report, you speak about disability and aging quite a bit, which we were obviously quite excited about here at the IFA. So could you share with us, first of all, maybe just start off with what disability is, and then how aging is both related to and different from disability?
Yeah, Kira, look, we probably need a week-long workshop on what is disability, but I'll do my best to, you think after 20 odd years, I'd be able to sum it up very briefly, but it is complex because WHO defines disability really as the interaction between, or the relationship between a health condition or impairment that somebody has and certain factors in the community, whether they are personal factors like someone's gender or sex or age, and environmental factors such as resource levels or stigma in the community. So all of those three come together to influence someone's experience of disability. And I'll give you an example. You could have two people of a very similar age, similar gender, and they could be both have the same health condition. They could both have blindness. Yet one person lives in a major capital city of a Western developed nation and has access to education and employment and supports, has a family and you know, basically participates on close to an equal basis as others. You take a same person, or you take a similar person, similar gender, similar age, exact same health condition, but they live in a small island state, or they live in a rural and remote area, or they live in, you know, a setting that is very, very different. Their experience of disability is completely different because of those different contextual factors, yet the health condition is exactly the same. And so we also see, and that's how WHO defines disability. What we see, though, is that every country defines disability legally very differently to each other. And we have the International Human Rights Framework in the Convention on the Rights of Persons with Disabilities, which really sets out that disability is an evolving concept and really relates to the interaction between someone's health condition and impairment and certain barriers in society. And those barriers could be stigma, and they could be physical infrastructure, could be a range of issues. What we've seen in the report, however, is that there is this close relationship between aging and disability. And, because we know that as people grow and they age, many of us will develop certain health conditions and impairments that impact on our functioning. And when we have those health conditions and impairments and we are confronted with certain barriers in the community, whether that's stigma and negative attitudes, or that's, the physical infrastructure or transportation, if that restricts our participation, then we can be experiencing disability. So there's also new data in the report that really demonstrates that the number of people aged 60 years or over with non-communicable diseases that can impact on functioning is much, much higher than it was in 2010. And we see, for example, that there's around 34% of older adults aged over 60 experience disability. So we have seen that increase. And a lot of that is to do with the fact that people are living longer with conditions such as non-communicable diseases, and we still have barriers in the environment that when people are confronted with these barriers, they experience disability. And I'll probably just add one more thing about disability and aging in terms of the report, is that we really see that a lot of the approaches in the report very much align or overlap with approaches that are happening in the aging space. We're trying to address disability discrimination or ableism, very, very similar to ageism, addressing that broader social construct of negative values, negative attitudes. We also see that there are important health conditions that people need to have access to address, whether that's through promotion or prevention. And older people and persons with disabilities can both be excluded from information that they need to address those health conditions. So there is quite a bit in the report on aging.
Yeah, and I think another focus in the report is this idea that an inclusive environment benefits us all. It's not an investment for a small group of people, because as you said, we know people with disabilities are not a small group. It's 1 in 6 individuals, but it actually just impacts us all in terms of we can get around our environments, we can just exercise our rights to be healthy and be a member of our community. So yeah, I think that was something that I really enjoyed about the report. So in 2011, the World Report on Disability was published, and this kind of addressed the ways in which people with disabilities are impacted across sectors such as employment, health, and education. Why was there a need for a report specifically related to health equity?
Yeah, so the report came at a direct request from WHO member states. So at the World Health Assembly, which happens every year in Geneva, all the countries come together and discuss certain priority health issues. And last year in 2021, the member states came together at the World Health Assembly and adopted a resolution on the highest attainable standard of health for persons with disabilities. And this is the first time a resolution like this has been adopted. And it had several requests of WHO in that resolution. One of them was to develop a global report on the highest attainable standard of health. So this report actually speaks to that resolution. But it really is an important time as to why we need a report like this, because as you may have seen in the report and others, if they've had a chance to look at it, we see that persons with disabilities experience significant health inequities compared to the general population. Some are dying, many actually are dying up to 20 years younger. Many have double the risk of developing chronic conditions or health conditions such as tuberculosis, obesity, cardiovascular problems, sexually transmitted infections. We also know that it's a state responsibility to address the health of the population. But what happens in the disability space is that when we talk about disability, ministries of health can often think that, oh, well, that's Ministry of Social Affairs, they're taking care of disability, so we don't have to think too much about it. But this is ultimately about people's health. And so ministries of health have a leadership role to play. And this report is very much squarely aimed at ministries of health to to show them that, there is a reason why they need to address some of these issues, and it's important that they understand that. And one more thing about the report I'll say is, this is the first time that WHO has done an economic analysis of the kind that we have in this report. And what we did was we reran some previously undertaken studies on coverage and on sort of return on investment, but we did it as in a way that was inclusive of persons with disabilities, because we already know that persons with disabilities are generally excluded from a lot of health promotion and prevention activities. And so when we ran the analysis again, it showed that for cancer prevention interventions, for every $1 invested, there could be a return of up to $9 for NCD, or non-communicable disease interventions and prevention. For every $1, there could be a $10 return on investment. So that's important, because often the narrative around disability inclusion or investing in disability is that, it's a one-way street. It's a luxury for rich countries, and, it's kind of, we're just supporting people in doing the right thing or the nice thing. This type of analysis kind of turns that narrative on its head and says, well, yeah, it is my right to be healthy, even if I'm a person with disability. But actually, if you invest in this way, it's a smarter way to go, because you'll get a stronger return. And as we've seen from COVID, governments have been pretty much slammed around the world in terms of their overall budgets, but particularly for health. So it's time we make smart investments, and disability inclusion is a smart investment.
Exactly, yeah. And a strategy I found really interesting that was included in the report was this identification of 10 entry points for disability inclusion. So could you explain how you came up with these and just tell us a little bit more about them?
Sure. So what we wanted to make sure is that in chapter 3, when we put forward, this is the way to go for ministries of health, this is what you need to do. We didn't want to create a parallel system or a plural kind of setup where governments are expected to do all these extra things, because that's often a criticism in the disability space, that they have to do extra things. So as many of you may be aware, WHO is supporting many, many countries around the world to advance universal health coverage. And there's an approach called the primary healthcare approach, which is the driver behind universal health coverage. And the primary healthcare approach is really about looking at making sure that you have 3 core components. One is around integrated services close to where people are. The second is about empowering communities and making sure they're part of the health sector planning and decision making. And the third is to make sure that we take multi-sectoral action, because we know that a lot of the drivers of good or bad health are outside of the health sector. So we need to engage other sectors. So we started with that primary healthcare approach as the foundation for recommendations, because ultimately we want countries to continue to invest in universal health coverage, but at the same time, we want them to do it better by making sure that they don't leave people further behind. So that was the foundation for the actions. And in the WHO primary healthcare approach, there are 14, they call them levers, but they're 14 sort of areas for action. And these areas are things like, health and care workforce, or health financing, or leadership, and models of care, things like that. And what we've done is we've adapted those 14 levers and put them into 10. So we think 10's a snappier number than 14. And we have, in those 10 strategic entry points or action areas, we have listed out disability targeted actions that countries can do to strengthen their approach in investing in the health system. So that's where we get the 40 actions for disability inclusion using that approach.
Excellent, thank you. And have you kind of, I guess, had the opportunity to see how member states have responded to the report? Have you heard any feedback regarding that?
Yeah, actually, we have. So straight after the launch on Friday, I was on a plane on Saturday, and I went to Saudi Arabia and presented the report and met with the Ministry of Health, and they were really, really pleased to see this, because again, for WHO, we haven't put out a report like this before that focuses on what can be done in the environment, what can be done in our institutions, as opposed to how do we fix people, or how do we address a health condition? So the feedback was very, very positive. And to go with that, we've already started working on a toolkit to implement the report. So we don't want the report to sit on a shelf. Nobody ever does, but often, unless you have kind of a next step, what to do with those recommendations, it's too easy to see the report just sit. So we've started working on a strategic planning tool that governments will use to be able to address the challenges in their health sector in accordance with the recommendations in the report. And that's being developed at the moment, and we're looking at identifying some countries that might be good to test this strategic planning toolkit, so that we can finalize things in the next sort of 18 months and have it available for all countries.
That's really exciting, and the IFA is looking forward to being able to support that. Another kind of aspect of the report that was quite, I think, evident throughout was this concern about unconscious bias amongst medical staff, and also the discriminatory triage processes for people with disabilities during the pandemic, especially. So how do civil society organizations such as the IFA, as well as concerned citizens, contribute to efforts to combating inequitable access to healthcare for people with disabilities?
Yeah, look, I think one of the things that, well, there's a couple of things. One is that in the report, throughout the report, we suggest that, well, actually, we don't suggest, we state very strongly that if we take a disability inclusive approach, as you said earlier, Kira, that it benefits the whole population, because we're talking about things like a human rights-based approach, which, there are many marginalized populations that experience, negative or discriminatory attitudes from health workers. Or we're looking at physical infrastructure. That's not just going to benefit persons with disabilities, it benefits everyone, where, you can have step-free access, or you can have, the types of physical infrastructure that we all know works when it is inclusive. Or we're looking at models of care, so that there are more community-based approaches, so that people don't have to worry about getting transport that's not accessible or not affordable. So I think the first thing is recognizing that disability inclusion in the health sector really benefits everyone. So we all need to get behind it, because it is something that is broadly beneficial. The second thing is we really need a culture change around disability. There are obviously very stigmatizing attitudes, even to the word disability. And you see people using things like, specially abled and physically challenged and special needs. And if you talk to a lot of persons with disabilities, they detest that kind of language. We have a convention, for right or wrong, the terminology is kind of there in the convention. Let's go behind the words and realize that actually disability is just a natural part of being human, that it is part of human diversity. And, many of us will likely experience disability as we age, if the circumstances are there. And it shouldn't be anything that worries us. It should be something we're all working towards to address, so that transportation, so that attitude, so that models of care in the health sector, so that the workforce, so that all of these components actually are ready for us and accept us, rather than us being the kind of odd ones out and trying to fit into a system that needs to be designed in a better way.
Exactly. So I'm going to turn to some audience questions. So first, we have one from Shmal, a regular who always has very interesting questions. So he asks, what is the role of governments and different authorities in improving well-being of disabled older adults from low socioeconomic groups?
Yeah, well, ultimately, governments have responsibility to ensure access to services for their population. Governments don't have to provide everything, but they need to make sure that there's access to. So we have the private sector, profit, non-profit engagement, and that's important. But government needs to regulate and needs to show leadership, so that people can take advantage and be connected to the services they need. And part of that is the governments need to understand what the priorities and needs of their constituents are, whether that is more or less related to employment, whether that is related to simply being able to participate and be independent. So I think there's two key roles. One is to understand what the priorities of the population are, and second is to ensure that there's access to whatever whatever aspects or components of the community that people need.
Yeah, and on that kind of strand of understanding needs, so I know the global report was informed by persons with disabilities. You engaged with groups quite a bit. How did you, I guess, open up that opportunity, and what was engaging with various groups and kind of different needs?
Yeah, so we undertook in the 12 months more or less of developing the report, we undertook over 30 consultations with stakeholder groups in each of the 6 WHO regions and globally in different time zones, and with UN agencies, with civil society partners. We worked very close with the International Disability Alliance and their members. We put our draft report online for almost a month for anyone in the world to make comment and give feedback. So we needed to make this report as open and participatory as possible. And through that we learned a lot, as you always do. And one example is around the investment case. The investment case that we put forward, we were very sure that this is an important message that needs to be out there. But there were some members of civil society that were concerned that it would sort of bring the discussion down to a financial one, and whether it's viable to provide service, etc. So that was important, because in the report we said very clearly that first and foremost it's a person's right to realize their highest attainable standard of health, and that goes without saying. But the reality is governments make decisions about how to spend money every single day. And we needed to have this information out there to say, it's not a bad investment to spend money to include persons with disabilities in health interventions. It's the opposite. It is a smart investment. It is a strong investment. So that was probably one of the biggest and most important discussions we had with some of the stakeholders around that narrative because of the sensitivities.
Yeah, and I think it also assists governments in when creating budgets for these programs. Of we know it's going to cost more initially. I think the estimate was 10% in the report, but we do know that we are going to get that back, right?
That's right.
So one of our IFA's UN representatives, Cynthia Stewin, has a question. So I don't know, Cynthia, if you'd like to ask the question yourself.
Thank you. My question is really, having worked in the field of aging my entire professional career, and also in the field of trying to keep people out of institutions, et cetera, and wanting people to age where there's the least restrictive environment where they want to live. I've always sensed a tension between those who have a disability either from birth or acquired early in life versus those who acquire a very serious disabling condition later in life. And it's there. I think there are a lot of explanations about longevity, and I think ageism starts very early in our lives, and that carries on. But I just wondered, with your wonderful expertise, and by the way, I attended the launch last Friday. It was really an inspiring launch, really amazing. So thank you. But I'd love your perspective on my question.
Look, thanks, Cynthia, and thanks for your words on the launch. I'm really glad it went the way it was. It went to, by the way. But look, there is tension for sure. There's tension, and I hark back to the point I made about my experience in Afghanistan with soldiers who were wounded from conflict and acquired disability versus a child who is born and has a particular health condition. I think there's no getting through that tension very easily. I think what is important, and the way that we conceptualize it, is that you have a broad population of people who experience disability. So in the report we have estimated 1.3 billion, or 1 in 6 people, experience significant disability. Now, out of that 1.3 billion, there is a subset of people who identify as being a person with disability, and they'll put their hand up and say, I'm a person with disability, and they'll use that as an identity, and that's great. but that's that subset. And then you have other people who may experience disability. They may experience stigma. They may not be able to access the community because of barriers. Their participation is limited. They experience disability, but they may never put their hand up and say, I'm a person with disability. And so at the end of the day, that's an important distinction for different people for different reasons. In WHO, our approach, we're taking a really broad approach, saying that anyone who experienced disability is what we're here for. Like we're here to make the health sector more inclusive for people who experience those barriers, to address those contributing factors in the report. So I think it would be far too ambitious of me or my team to think that we could address that tension. We recognize it, but we're just going forward and saying there are contributing factors. People are dying younger. People are having more difficulties functioning because of the barriers in the community, and people are sicker. We need to address this. So that's kind of our position. But happy if you've got any ideas on addressing that tension.
Thank you for that. So I think Chris Kobus has a question about invisible disability and a bit of a follow-up on tension. I don't know, Chris, if you'd like to ask your question.
Hello, this is a very interesting discussion. I'm involved with a disability coalition in Ottawa, Canada, and I'm anxious to share some of this information or pass on links to them. Just in follow-up to the discussion about tension, I'm not quite understanding. Are you talking about tension between those two groups of people, or tension with regards to how the community may treat those two different groups of people differently? I just wanted to ask that first.
Yeah, maybe Cynthia, you might be best placed on the. I'm happy to chime in, but Cynthia, I don't know if you want to respond to Chris on the tension question since you raised it.
I'm sorry, my grandson had just asked me a question. Oh, Chris, I think I met you actually, but anyway, repeat what you have a problem with the.
Well, I wasn't sure what you were meaning by tension, whether you were saying, is there tension between those two groups of people you described, or is it a tension that exists in community because those two different groups of people are often treated very differently with respect to discrimination by community?
Yeah. I understand, and I thank you. I think what it gets at is that older persons as younger people don't experience ageism. But I think people with disabling conditions earlier in life experience much the same experience as an older person does in later life, regardless of disability.
Okay,
you go to a restaurant as a disabled person in your 40s, and you will likely have a wait person say to your person accompanying you, what would she like for dinner? You know, and that's, you know, if you're hearing impaired or maybe you're blind at a table in your 80s, the same exact thing will happen. So there's commonalities, but I do think it took the movement of the disability community, if I can be broad stroke, that brought attention to the need for where we are now, which is the least restrictive environment, is where anybody wants to live. And older persons and younger people share that same thing. I just don't think we're all there yet, but I think the WHO, particularly with the decade of healthy aging, and now, you know, and with your report, is really moving us in that whole, regardless of age, it should be friendly environment and least restrictive. That's what I was getting at. So
thank you, Cynthia. That we're on the same page. That's what I just wasn't sure if there was something I was missing there. The other question that I had was just, I wondered, Darryl, if you could speak to invisible disability versus physical disability and how that plays out and so on.
Yeah, look, it's a good question, because people raise this quite often around invisible disability. And for us, again, if we start at our WHO concept of disability, it's really about a health condition or impairment that interacts with different either personal or environmental contextual factors. And those health conditions or those impairments don't need to be obvious. They don't need to be something you can see or feel. So, for example, one of the most common ones that is put out or we discuss is around mental health conditions. So, mental health conditions, conditions such as anxiety or depression. It can be episodic, so it can come and go, even though it's long term. It can be something that's not necessarily visible straight away to someone, but if somebody discloses that they have a mental health condition and they're stigmatized against, they can then experience discrimination or ableism on the basis of that health condition and in relation to disability. You also see other health conditions such as some communicable diseases and non-communicable diseases. So tuberculosis, HIV. So people who have health conditions that don't always manifest themselves in a physical sense, but if a person needs to apply for insurance or for residency permits or something like that, they might not be able to do that equally as anybody else because of that health condition. And many countries protect people on the basis of disability discrimination law to address some of those issues. So in WHO, we certainly take, again, a very broad approach that disability can be a result or can be contributed to by a range of health conditions that either manifest themselves or they don't manifest themselves. We take a very, very broad approach in that respect.
Thank you.
Yes, and thank you everyone for the questions. It's been really interesting discussion so far. So I know Dominic Boyd, you have a question about acquiring disability later in life and kind of this idea of normal aging. I don't know if you'd like to ask it yourself.
Oh, sure. It seems to me that there's a lot of effort gets put into helping younger people and children who have disabilities. When someone gets older, 60s, 70s, 80s, and develops a disability, we actually treat them as if, oh, well, too bad, it's just getting old, these things happen to everybody, sort of thing. I think it's been my impression that there's two levels of how we respond, to younger people versus older people. So I haven't been able to see this report yet, but I'm wondering if that's kind of addressed in some way in your report.
Thanks, Dominic. Look, I think the short answer is it's probably not addressed in the way that you frame it, partly because so in the report, we don't separate out people according to age. We do put in examples around the impact of certain factors on children that contribute to them having disability and experiencing poor health. But we do that also for older people. We highlight that older people experience significant barriers in the health sector, and older people with disability are at disadvantage compared to others. And again, I'll default back to the broad approach that we take in my team, is that we very much are looking at a systems approach. What do we need to address in the system so that regardless of your age, you have the same opportunity to realize good health, whether you are a child, an adolescent, someone in your middle years, or someone who is older. And you're right, there are particular barriers and challenges that children experience that older people don't, and vice versa. And I guess that's probably why the work on the decade of healthy aging is so important, because there are specific barriers, specific issues, whether it's ageism, whether it's this policy differential I was talking about that we see in Australia, that need to be addressed because they impact on people's health. But in the report, while we don't tackle that point head on, we do highlight that different people at different ages experience different factors that drive disability for them. But I'll be interested to see what you think when you have a chance to read the report, whether there's something that we missed along the line.
Thank you.
Wonderful. Thank you very much. So I know Eileen from University of the Third Age, she has a really great question about budgets and priorities. So Eileen, would you like to ask your question?
Thank you very much, Sherry, and thank you very much for an excellent conversation. You mentioned during your discussion that you won arguments or presented arguments from an investment perspective. In Ireland here, we have a policy, it's called Sláinte Care, which is good health, is right care, right place, and the right time. But I joined a session recently to have webinars, and they were talking about all these great programs that they have that they've invested in. But then when somebody asked how about rolling it out, all of a sudden, the officials from the Department of Health said, well, if it aligns to our strategic priorities. So have you come across that conflict or tension, to use that word, between strategic priorities that are really within the next 12-month budget cycle? Does that make sense to you?
Absolutely. And to answer your question, probably every day of my life, in my career, I've come up against that challenge of, well, it's not in the strategy, or it's not sort of, does it align, because it, and I think this is where some of the intersection between aging policy and disability policy is very close and very important to work together, because disability can often be seen as a special thing to do for a small population, and something that is, kind of, yeah, let's do it if we can do it. And trying to get governments to understand that, first of all, it's a significant proportion of the population. Second of all, that if we're not designing our policies or our programs or putting legislation down that addresses some of the most marginalized in the community, then who are we really designing these strategies for, and these programs for, and these policies for? So a big part of the reason for this report is around advocacy. As WHO, we're meant to put forward the evidence and not be too strong on advocacy, but say, this is what the evidence says, these are what our recommendations are. But the reality is, a report like this, as you've probably seen in the aging space, is really powerful to start changing the discussion around what should be part of a strategic priority. And so we give the example in the report in chapter 3 around what can be done in the health sector. So if we look at the workforce, for example, we very much are promoting sort of a human rights-based approach to addressing the barriers in the health sector. And one of those is addressing the negative attitudes of healthcare workers. And I'm sure it's very similar for older persons in terms of accessing particular care or being referred on to particular programs. When governments are investing in training for nurses or doctors, undergraduates, postgraduates, whatever, if they include competencies or training around disability, then we will more likely have a workforce that is confident and competent to be able to deliver what's needed. And that doesn't take a huge shift out of the strategic priority of workforce development or workforce upskilling. It's just a matter of us being able to tell governments and share this information and say, it's possible, but you just need to be conscious of it. So a big part of this report is bringing that consciousness to the policymakers.
Thank you very much. And I think Jane with the IFA has a question about WHO guidelines.
Thanks very much, Kira. And this has been an excellent conversation, Darryl. Member states look, watch and listen to WHO guidelines and leadership, and particularly in the decade and with the release of the report, it's a unique opportunity. To what degree can we be hopeful that the disability portfolio in your leadership is actually intersecting with aging and health towards a visible statement about the importance of, this common agenda? Because otherwise we've got member states, that are actually pulling on different portfolios, and that makes it very difficult for us to advocate.
Yeah, look, it's a really good question. Look, we'll probably start at the intersection or sort of where there's some really good alliances that we can have. And one is around the fact that as we all age, we are, if we're lucky enough to live to a ripe old age, we're probably going to experience some health conditions or impairments that are going to impact on our participation. So knowing that there is that relationship. Also knowing that persons with disabilities are aging and living longer. And so we need to make sure that there are policies in place that support persons with disabilities as they get older. So I think the first thing is recognizing that we really are we are strong allies, even, and I know we realize that, but we probably haven't capitalized on it as much as possible. So that's the first thing. What does that alliance or allegiances really mean? The second is really important because, as you say, we don't want to keep creating sort of competing priorities at the country level for governments to say, oh, hang on, we're doing this, but then we're doing that. Where do we put our money? So whether it's recognizing more common issues around, again, around workforce curriculum, making sure that when a country X is doing transformation, like I said, I was just in Saudi Arabia, and they, from early next year, they are undertaking a massive transformation where they will prioritize Ministry of Health actions to policy and regulation, and they will outsource a lot of the service delivery to the private sector, profit, non-profit. So there is an opportunity in a country like that to say, okay, so what do we need to do to make sure that service delivery is done in a human rights based way, so that we're not seeing any type of negative stereotypes, so that people are referred to what they need to be referred to, and there's a certain quality of care. Or looking at even the models, how the models of service delivery are undertaken. We know that for many persons with disabilities, transportation can be a major barrier to accessing care. It's similar for many older people. Transportation in a lot of cities is not accessible. And so looking at some of those overlapping areas of action, I think, is the other area that we could say, okay, let's present perhaps a bit of a unified front, so that we're addressing the factors rather than addressing the agenda.
Okay.
Thank you very much. So I think we just have time for one more question or comment. I know there's a question from Juringho. She is wondering about the effect of disability and physical well-being in long-term care facilities despite functional activities. So what can we kind of do to improve, I guess, functional abilities of those within long-term care facilities?
Yeah, look, in the report, we highlight that the location of where somebody lives, so their living conditions, impacts directly on their health. And we know from COVID that people living in long-term care facilities or residential facilities were disproportionately impacted by COVID because of all the reasons that I'm sure everyone on this call understands. So I think that there's a few different things we need to look at, but partly it's dependent on what actually the issue is, because is it a matter of staffing levels? Is it a matter of staffing quality? Is it a matter of the way that the long-term care facility is actually run, like the governance of it? Are persons who are resident, who are living in that facility, are they part of the decision-making process? So there's sort of a cultural aspect. There is the workforce aspect, both quality and quantity. And then there is just the fact that we need to be changing, again, this culture around what it means to age in a healthy way. We want to be able to, people want to be able to age in a manner that is dignified, that maintains functional independence as much as possible. But that's all, a lot of this is cultural change, which takes time, unfortunately. The good thing now with the decade and with a report like this is that we have evidence and we have some momentum. So it's getting more and more difficult for policymakers or people in position of authority to kind of say, well, we don't know what to do, or no one's really interested. We now have some more evidence that makes that a little bit more challenging for them to do.
Exactly, and it's very encouraging to be able to be part of that. So thank you very much for being so generous with your time. We're unfortunately reaching the end of our time together. So before we move on to some key takeaway messages that you'd like us to kind of keep in mind, I'd like to announce next week's speaker. So Bruna, if you could share screen. Fantastic, thank you. So next week we have Mr. Kenneth Magayuwenki from Reach One, Touch One ministry. And we'll have a presentation or a discussion on overturning the ageist preconceptions in Eastern Africa. So looking forward to that next week. So Darryl, what key messages would you like to share with us? What should we keep in mind? What should we take away from this wonderful discussion?
Look, I think first of all that there are a lot of benefits for the disability community and the older persons community to join forces. I think that's a given, and I'm sure most people on the Zoom today would see that, hopefully. So I think that we have an opportunity to really strengthen our collaboration and our cooperation. The second is to make sure that in that collaboration and cooperation that we make it simple for governments to do what they need to do, and that we try as much as possible to not compete. But it's difficult in this current setup of funding and trying to resource what we do. But I think that always needs to be at the forefront. But I think finally, or the main takeaway would be that investing in disability inclusion in the health sector is really an essential investment in good health for everyone, including good health of older persons. So that would be a takeaway, that if we invest in disability inclusion, that is going to make a tangible difference to everyone, including, but particularly for older people. So yeah, I'll probably stop there.
Wonderful. Thank you so much. The IFA looks forward to working with you in the future and supporting the report and using the report in all of our work. So again, thank you very much. And thank you everyone for attending. It's been a wonderful hour and we're looking forward to seeing you next week. Have a lovely weekend.